Hi there, it's Sarah here from BJC Health, coming to you from Sydney, Australia. Thanks for showing an interest in one of our educational events. You're about to watch part one, so enjoy the event. If you've got any questions about the content, then please consider joining BJC Connect, where you can access all of our facilitators live. Otherwise, please consider leaving a comment and we'll do our best to get back to you.
Good evening, everyone. Thanks so much for joining us. It's really nice to see you all here on this cold night. And yeah, very special for Rob and I to be able to present together, which is going to be good. So let's get started. So first of all, what is hip osteoarthritis? I did have a think back to our recent Connect talks, and I don't think any of the physios or exercise physiologists have talked about osteoarthritis in our recent one. So I thought we'd give a bit of a background to start with. So osteoarthritis, obviously a bit of a long word, like a lot of medical terms. Osteo means bone, arthro is joint, and itis is inflammation. So according to the word, it's bone or joint inflammation. Quite true, I guess, when we think back about the conditions we see that fall into the group of osteoarthritis. But pretty much osteoarthritis can affect any part of the bone or joint around every joint. So it can be the joint itself, it can be the cartilage, things like meniscus or just the joint surfaces are considered cartilage. It can be any of the ligaments around any of the joints. It can be any of the tendons that can be affected. So a tendon is the part of the body where the muscle attaches to the bone. So for example, the Achilles tendon you may have heard of, or it can be something called the synovium, which is kind of like a fluid-filled sac around the joint. So if any of these parts of the joint show changes or inflammation, it can be categorized as osteoarthritis. So tonight we're going to be more specific and talk about the hip joint and osteoarthritis that may come into that joint. Okay. So just a bit more about osteoarthritis in general before we hone in on the hip joint. So on just the picture, I'll go through that first. So on the left, you'll see the femur or your thigh bone, and there's that little bit around there, which is the joint space. So you can see in this picture, maybe hard to see, I know it's a bit small, but the gap around the femoral head to the pelvis is kind of even all the way around. So you can see there's quite a nice, what we call joint space. In this one, you can see around here where my cursor is at the moment, there's not really a joint space. And even around here, it's a bit narrowed. So potentially, I'm thinking there is some arthritis in this joint as the joint space isn't quite as clear and nice as this one. So hopefully some of you guys can see that. Just a few facts about osteoarthritis, as it is something that we see a lot at work. So 30% of those over the age of 65 are going to be affected by osteoarthritis. And this increases to about 50% in the 85 or plus age group. At any one time, 15% of Australians might be dealing with the impact of the condition. So it might be affecting their quality of life, their function, they might be in pain. Unfortunately, osteoarthritis is more prevalent in females. Typically, I guess in the hip, potentially in the knee, maybe even the ankle joint, I'd say we see it definitely in females just because our body shape's a bit different and our alignment is different to men. And very much something that's important, and we'll mention a few times tonight, pain can be multifactorial, but it does not always reflect damage. So what we mean by that is that someone might have a lot of changes on their X-ray or their MRI. They may have no pain at all. Or conversely, someone could have a lot of pain on their X-ray or their MRI. And they may only have, so they may have a lot of changes on their scan and have no pain, or they may have no changes at all, but display quite large amounts of pain. And we know other things like what you're doing day to day, maybe how much activity you're trying to fit in, how much sleep you're getting, how much stress you're going through, things like that can affect how your body is coping with pain. Okay, so just a bit of a background. So the hip joint simply is where the the femur or your thigh bone attaches into the pelvis. So we call this a ball and socket joint. So pretty much the head of the femur is a ball and then it attaches to the socket, which is the pelvis. This is very similar to the shoulder joint. So if you've attended any of our shoulder talks, you might be familiar with some of the information we share tonight. And typically, I guess with rehab, we do address the joints somewhat similarly. So it's very different to, the joint itself is very different to, for example, the knee joint, which is what we call a hinge joint. So that's a much more simpler and it only bends and straightens. Whereas the hip joint and the shoulder joint, it goes in all different directions and different types of rotation, which sometimes can make, I guess, rehab a little bit more complex. But the joint itself, because it is a ball and socket joint, you can see on the picture on the left, there's lots of different ligaments, and these help attach the joint or the bones to each other. But what it also means being a ball and socket joint is there's a lot of sometimes what we call instability in the joint. Okay, so if the muscles around the joint aren't strong enough, it puts a lot more stress onto the joint because there's not as much surface area as something like the knee joint. The picture on the right, so this is just the picture of the back of the hip. Obviously, there's also the front of the hip, the side of the hip. The hip really has a lot of different muscles. I'll point out a few of the main ones that some of you may be familiar with. There's the gluteus maximus muscle. This is the biggest muscle in the body, but one of the big muscles that really extend the hip backwards. So that is the top layer of the back of the hip or the glutes. But what some of you may be unaware is under that glute muscle, there's actually lots of other layers of muscle. So the one directly under the gluteus maximus is actually called the gluteus medius. So that's another big muscle that often with exercises or with manual therapy, we like to work on. And then even below that, there's other muscles. Some of you may be familiar with the muscle called the piriformis. And then even below that, there's even deeper muscles. So the hip joint is really complex, and that's just looking at the back. Okay, so in the front of the muscle, in the front of the hip, there's a group of muscles called the hip flexor muscles. Some of you may have heard of, but that's also another group of, I think, 5 or 6 different muscle groups. And of course, that also comes in different layers. So when we're thinking about exercise and rehab, when Rob and I are trying to design programs, we might try and target which muscle group or which area isn't working as well, isn't strong enough. And that sometimes can take a little bit of either trial and error or more assessment to figure out which muscle group we really do need to work on. Sorry, something Robyn, I think, forgot to mention. So if you have any questions, pop them in the chat and we'll either answer as we're going if we have time, or we'll stop and answer, or we'll have time for questions at the end. So please ask any questions. We'd love to see what we can help you with in terms of filling the gaps of knowledge. Okay, if any of you have attended our previous Connect talks, you may be familiar with this table. It's a general table that covers all our guidelines for osteoarthritis, not just the hip, but something we like to work through to make sure we're giving the best evidence-based practice for osteoarthritis. So in order of priority, one of the first things in any weight-bearing joint we're looking at is going to be to see if we can manage any excess weight or look at weight loss or management. So this is a really important fact to remember, but 50% of reduction of osteoarthritis symptoms can happen with a 10% reduction in body weight. And it can also give a 40 to 50% reduction in pain. So that's quite significant, I'd say. So what this means is let's say someone is 100 kilograms. If they can lose 10 kilograms, which for some people can sound like a lot, but it really is 10%, it can give up to a 40 to 50% reduction in pain. Now that's quite powerful, I think. Obviously, we understand weight loss and management isn't always very easy, especially if you're in pain. So that's where someone like myself and Robyn can often go through different options, or even your GP. I think Robyn's going to go more into weight loss later in the presentation as well. The second treatment option that's very well validated is exercise. Again, we both understand that exercise can feel very hard to do when you are in pain, but I guess it's our job to I guess tailor the right exercises according to what you can do at that present time that you see a physio or an exercise physiologist. So different sorts of exercises can help. And of course, there's always options like hydrotherapy, exercise bikes, cross trainers, things like that, that we can what we call non-weight bearing exercises. And in the case of hip OA, they can be very good ways to move the hip without hopefully causing too much pain. Okay, between 3 and 7 are all things that you can do to help with pain. So topical creams, they have a lot of evidence. Non-steroidal anti-inflammatories. Obviously, you can follow the GP and the pharmacist's advice for just the over-the-counter ones. Otherwise, if you are in a lot of pain, you might consider seeing someone like a rheumatologist who might give you something that's a bit more tailored to what's required for your current level. I'll cover this a bit more later, but braces, walking sticks, and other aids can be very, very important and very, very useful in just giving you a little bit of pain relief so that you can walk a bit more, do a bit more exercise, and just generally function a bit better. And it's a really, really good adjunct to what your physio may be doing in the room, in your treatment cubicle. Some doctors may refer you for intra-articular injections. These can give very good short-term relief, but short-term relief is probably the key here. So for a lot of people, if you just do the injection and you don't do any rehabilitation with your physio or your exercise physiologist, unfortunately the pain can come back. But where injections, I see it work really well, is if people are really motivated to hopefully not have pain or dysfunction again, they can have the injection and it enables them to do a lot more exercise or movement so that they can, helps them lose weight, get more muscle strength, so that hopefully, even if the injection does wear off, they're in a much better place. Paracetamol obviously can be very helpful. And the last five things in the table, they're often things that your doctor or your specialist may talk to you about, but they're not as well advocated according to the current research. Okay, so moving along. So if you do happen to have hip pain and you go to see your physiotherapist, these are some of the things that in that initial 1 or 2 sessions they might look at to determine your level of function. Okay, so first little gait. For most physios, they're going to be looking at how you stand up from the chair from the waiting room. They're going to be looking at how you walk into the room. Are you limping? Are you do you have a short stride length? Are you well balanced? Do you swing your arms? Things like that can be very important to give us a full picture. And then it gives us an indication of how you might be getting around at home, maybe how you might, if you're managing at the shops by yourself, things like that, which are really important. We will, in hip patients in particular, we might be looking at how you're standing or walking. And if you've got, so this picture here, anything what we call a Trendelenburg sign. So that's when the hips may not be aligned very well when you're walking, but what that tells us as a physiotherapist is perhaps one side of your hip muscles aren't engaging as well. Other things that we will typically look at in that physio assessment is single leg balance. It's just, again, to gauge an idea of your strength and balance, but also, it's important that we attain this information because if your balance is poor, you might be more of a falls risk. And these are important things that we need to work on. Something which I like to look at is a double leg squat and also a single leg squat. A single leg squat for many people does seem quite hard, but actually, if you are able to walk up and down stairs, it's actually a single leg squat. So for most people, if they want to be independent, if they want to get around at the shops, we want to make sure that either assisted with the arms or unassisted, that you can do a decent single leg squat. What a double leg squat tells me typically is how well someone might get down to the floor, how well they might be able to put their pants on if they need to bend down to get one leg in, if they need to bend down to pick up grandkids, how well they do things like that. And then we're also asking about obviously if there's any pain, but more importantly for your therapist, they will probably be looking at how you do these movements. Okay, so other things that we might look at in that initial assessment, we look at the back, the knee, and the ankle range. So obviously you probably all expected that I'd say, we look at the hip range, and of course we do that, but it's actually important that I get a feel of how your whole body moves together. Because if the knee doesn't bend well, or if the back doesn't move well side to side or rotate, it actually puts a lot more stress onto the hip joint as well. And then that might explain to me why you have pain or dysfunction in that area. So we like to look at the full picture and how you get around and move. I put a picture of the big toe because some of you might be wondering, what does the toe have to do with the hip? Well, actually, it's quite interesting because we now also know that if your toe doesn't bend well, so into that what we call dorsiflexion movement, it just means that your hip actually your hip muscles have to work harder every time to push off when you walk. If you're a runner, it's going to be even harder. So something as little or as big as a big toe stiffness can cause problems up into the hip area as well. So it's important that, we really do look at the full picture. Obviously, I'm going to look at your hip movement in standing and in supine, which means I'm lying on your back. So it might be, how well you bring your knee to your hip. Does your hip actually turn in and out? And of course, when your physio checks you on the bed and you go, I never bring my leg around like that. It feels a bit funny. But what it tells me is how well you might be turning actually when you stand in the kitchen, or how well you might get in and out of the car. So things like that can be form a nice piece of the picture for me. I'm also going to look at your muscles, so how flexible they are and also how much strength you have. And then based on all these things I might find in the assessment, I then hopefully will be able to kind of figure out what we need to work on and where we need to go with the further management of your hip osteoarthritis. Nope. Okay, so I just want to touch on this. So often when one has hip pains, there's some things that you can do yourself to reduce your pain day to day. It does take a lot of mindfulness and caution, but if you can reduce some of these movements day to day, it can actually reduce your hip pain quite significantly. So some of the simple ones for females, definitely try not to sit cross-legged. What sitting cross-legged does is it puts more stress onto those muscles on the outside of the hip and then can cause the joint pain. We try not to sleep in this position, again, where your knee crosses the midline. When you're standing, we'd like you to stand evenly and not put more weight onto one side. Something that can really help with your function, again, is not trying to avoid sitting in low chairs. And another one for sleeping. So some people will complain about their pain while they lie on their side. So putting a pillow between the legs can help significantly. It's important that the pillow is of a decent height though, so that we want your legs to be parallel to each other and parallel to the floor. Okay, so hopefully these are things that your physio might discuss with you in this early stage management phase, because if you can do some of these modifications, if we can get your pain relief down, you're going to feel a lot more like moving again, you're going to feel like exercising again, and hopefully getting a bit stronger. So in this early stage of management, once you see your physio and you've done a bit of assessment, it's really just hopefully to first of all reduce your pain. So some of the things that we might do to help you reduce pain, we might look at your activities. So how much you walk every day, even actually how much you sit every day. Because if you sit a lot and don't walk enough, the joints can obviously get a bit stiff. So it's a bit of a balancing act sometimes to figure out what the right amount of walking, movement, or rest you should be doing as well. A lot of patients can get a lot of relief from manual therapy from your physio. So we might be massaging the muscles around the back of your hip. We might be looking at your groin area or your hip flexor area. And as I said, even if there's any areas of like tightness or stiffness in the back or the knee, these are also areas that your physio might look at. And then hopefully from that, your physio may also tailor you some activities to do at home to help with the things that they're working on in the session. So one thing that I like to give people a lot is different ways of working on their muscles around the hip by using the spiky ball. A few months ago, Sarah and I actually did talk on using the spiky ball, and I do remember we covered some of the hip muscle groups. So that is something that you can all go back and look if you're interested. But the spiky ball can be a really, really good adjunct to your physio sessions and keeping those muscles a bit looser. Taping and bracing, I mentioned it in the table for the OA management, but this is definitely something that can give a lot of pain relief. And the idea is that hopefully if we can give you that pain relief through taping and bracing, we can encourage you to do more exercises and then hence have a better outcome in the long term. So the brace that we have on the left here is a brand called Bowfine. So that's to support the hip joint, and probably a little bit less invasive and cheaper, I guess, would be the options of taping. So typically your physio might start with that. There's lots of different ways you can tape for the hip. So I put 2 different examples, and often with your physiotherapist, it may be a little bit of trial and error. And then some examples of some exercises. So hopefully after they've done the assessment, you hopefully are also feeling a little bit better from maybe some of the treatment they've given you a session. We want to supplement it with some exercises. So initially it's to get some of the muscles that may not have been working because you've been in pain to start working a bit better. And then Robyn in a few slides time, we'll talk about the end stage management. But some examples of things that we might do. So this exercise at the top is called a bridge. And it's really to get the glute muscles working and the hamstring muscles. We might start giving some balance exercises. We might do some core exercises. So this is one example, it's a side plank. And then progressively, if these bed exercises or the exercises not on your feet are getting a bit easier, we might move into a squat or even a single leg squat. And as I mentioned in the assessment before, the single leg squat is something I typically like most patients to be able to do. Okay, I'm going to pass it on to Robyn now. She's going to take you through a bit of the EP assessment.
Cool. Thank you, Belinda. Hopefully you guys have picked up a few things just from the physiotherapy side. You'll notice some of it overlaps with the exercise physiology component that I'm going to bring in. And I suppose in a perfect world, and sometimes Belinda and I do get to work together where someone might be seeing a physiotherapist first to again get that initial assessment, get some manual therapy, start to work on some modifications, and then the physio might refer them on to an exercise physiologist where we can start to look a little bit more global. And when I say global, again, I know that we're talking about the hip today, but as Belinda said, things can start to go up or down the chain and affect your hip. So from an exercise physiology perspective, I'm now looking at functional limitations. So what I mean by that is, what are the things that you want to and need to do day to day? You might need to climb stairs, getting out of beds, getting out of cars where you've got to rotate the hip, get into some of those funny positions. It might require lifting things, lifting little humans, getting down on the ground, gardening. So those sorts of things I can imagine you might be limited by, and of course want to still keep doing. So my job is, how can I still help you live your life and do those activities? But I need to understand what are the things that you want to do day to day. So part of that will be just from the history taking and really just getting a picture of your life, plus then looking at how you might do some of those activities and getting you to just show me how you move. Psychosocial barriers I put in there. Belinda talked about pain. She talked about, again, how lack of sleep, stress, a lot of just stuff going on in our lives, relationships, etc., can impact pain, and it's very multifactorial. So yes, we can look at the hip, we can just look at your function, your strength, but sometimes that can be all good, or we can go, okay, yes, you're missing something here, but if there's a lot of other stuff going on psychosocially, that can also impact your pain, and we don't want to ignore that or sweep that under the rug. I will ask normally about activity levels. So that's just, I guess, in general, exercise and what exercise you're currently doing, even just incidental movement. So again, for me, it's to understand, are you generally active through the day? Do you do a lot more sitting? Is your job, desk-based? Are you, sitting in chairs and couches a lot? Are you doing a lot of driving? Because your overall activity levels really make a difference for me to understand how much your joints sort of, it's stiff positions, if things are getting tight, Maybe again, you're doing too much. So yeah, that's very helpful to then gauge where to start things and maybe where to pull things back as well. And as well as also just understanding your history of activity as well. So where you might be now in terms of activity might be very different to where you were 6 months ago, a year ago, 5 years ago, as well as the amount of, I guess, exercise you've done. So, someone who's maybe been to the gym and has done a lot of maybe strength training or lots of aerobics before versus someone who's never done any exercise, that'll also impact I guess the journey moving forward, and for me to understand how your body has evolved over the years and what level of strength you'll have, and can often make guesses already as to how you'll function at the current time without even looking at you. Similar to Belinda, as she did some tests to look at your balance and how you might squat or how you might single leg squat, we look at biomechanics. So again, perfect situation is maybe I'll see someone who's come from physio, but if you've not seen a physio and I'm seeing you, then I get to look at you for the first time and look at how your alignment is. So when we talk about alignment, when you're doing things like squatting, stair climbing, standing on one leg, where are the joints aligned, and as Belinda mentioned before, you might have heard her say the word Trendelenburg, but that actually just shows us your hip alignment and what muscles are working or what muscles are weak. So it's really important to understand if you've got adequate biomechanics or if things are not working quite as well as they should, because every step you take, every time you get out of chairs, if your biomechanics is not good, you're going to just put excess load through the hip, then potentially through the knee, then potentially through the ankle and the back. And so you can start to see why you might have more pain if your biomechanics aren't as adequate as they could be. Also, we'll look at your gait, have a look at, if you are making compensations, if, you're walking slower than normal, and have a look at, where there might be, again, weaknesses or imbalances that we can actually help improve your gait, especially if walking is something you want to do more of. And then same thing in terms of muscles, I'm going to look at your strength in some similar positions that the physiotherapist might have looked at. Again, I'll try to look at function as well, because I think that's very important when you are trying to maintain an active lifestyle or want to be involved with, kids and family. So sorry, that was a bit long-winded, but it's a lot of me understanding the history and then having a look at how you move physically as well.
So you've just finished watching part 1 of one of our recent educational events. Hope you enjoyed the content. If you'd like to access part 2, then you need to sign up for BJC Connect. It's a free platform where you can access not just the recordings of past events, but also access a whole range of upcoming future events and access our team of facilitators live. All of the details that you need to join BJC Connect are now flashing up on your screen. But otherwise, like our staff, subscribe if you'd like to see more information from BJC Health. Look forward to seeing you in an event soon.